morning to my respected teachers, seniors and my colleagues. Today I am going to present a case of 45 years female with the right buccal mucosa carcinoma. I am Dr. Monalisha Khan, second year MCA president of the Surgical Oncology department, and I am going to present this case under the guidance of Dr. Eshita Sharma sir, and professor and the head of the department, and Dr. Rahul professor with the assistant professor of the department. I am going to present the patient details. There is a 45-year pleasant lady with a tobacco chewer, married and a homemaker, and the resident of the Jaipur presented to Mahatma Gandhi College with a complaint of non-healing ulcer over the right buccal mucosa for last 3 months. There is no history of the similar complaint in past, and there is no history of pain and bleeding. There is no history of any dental and intervention as well as trauma, and there is no other history of the numbness and the altered sensation over the cheek or the lip region, and decreased mouth opening, as well as there is no history of any neck swelling. There is also no other history like the fever, jaundice, chronic cough, weight loss, and recent onset of the bony pain. Come to the past history, there is no history of diabetes, hypertension, and tuberculosis. There is no previous surgical history, and there is no history of any drug allergy. She was a tobacco chewer for last 20 years, 4 to 5 packets per day, and she stopped the tobacco chewing for last 3 months. Para 3 and the life, she attained menopause since 2 years. There is no history of alcohol intake and smoking. She is a vegetarian by diet with a normal appetite and normal bowel and bladder habit as well as normal sleep pattern. There is no significant family history in this case. In come to the general examination, she was alert, conscious and oriented to the time, place and the person. The temperature was 98.4 degree Fahrenheit. The pulse was 80 beats per minute with normal rhythm, tension, force and volume. Blood pressure was 126 by 78 mm of mercury over the right brachial artery on supine position. Respiratory rate was 18 cycles per minute, which was thoracic abdomen. Patient was fairly built, fairly nourished, normal gait. The height was 156 cm and the weight was 50 kg. Body mass index was 20.55 kg per meter square. The performance status was equal 1. The back and the spine was normal, and there was no pallor, icterus, clubbing, edema, and generalized lymphadenopathy. And come to the oral examination. On inspection, there was no trismus, there was no, the intra-incisor teeth distance was 3.5 cm. There was no oral submucous fibrosis. That means there is no fibrous layer over the oral mucosa, which can cause the restricted mouth opening. And there is, the patient was dentulous in the lower jaw. There was partially dentulous and some teeth was absent. Nicotine staining was present over the teeth. The halitosis was present. That means the odor, unpleasant odor, the exhaled air. And there was, because of the food material which got stuck in the ulcerative area and what is the bacterial overgrowth and as well as unpleasant odor. There was no leukoplakia and no erythroplakia in this. There was a single ulcer proliferative lesion which was 3 into 2 cm in size over the right buccal mucosa with everted margin and irregular surface. Anteriorly, it involved the right commissure reaching posteriorly 2 cm from the retromolar triangle, inferiorly up to the lower gingivobuccal sulcus, from canine teeth to the first premolar teeth, and superiorly 2 cm away from upper GTS. The lesion was not involving the alveolar mucosa. Externally, it was involving the skin of cheek region along with the right commissure about 1 into 1 cm in size. The rest of the oral cavity was normal. There was no fullness noted in the neck. On baptism, the inspectory finding was confirmed. A single 3 into 2 cm ulcer proliferative lesion in the right buccal mucosa anteriorly involving the right commissure, reaching posteriorly 2 cm from the rectomolar triangle, inferiorly up to the lower gingiva of the sulcus, from canine tip to the first premolar tip, superiorly 2 cm away from the upper GBS, and inverted margin along with the irregular surface and the floor with the necrotic tissue and the ulcer bleeds on touch, not involving the alveolar mucosa, and externally it involving the skin of cheek region along with the right commissure about 1 into 1 centimeter in size. There was a single 1 into 1 centimeter over hard mobile nodule swelling over the with the normal overlying skin noted at the level of right level 1 big region. No other palpable lymphadenopathy in neck and the other part of the body. Other systemic examination was normal. And the respiratory there was bilateral air entry was normal and thoracoabdominal distribution. And series there was normal H1, H2 sound was noted, and abdomen there was soft, non-tender, and no the history and examination summary was like 45-year present lady who was a tobacco chewer presented with the ulcer at the right buccal mucosa for last 3 months. The ulcer at the right buccal mucosa size was 3 into 2 centimeter, anteriorly involving the right commissure, reaching posteriorly 2 centimeter from the RMT, and inferiorly up to the lower gingiva of the sulcus, from canine tip to the first premolar tip, and superiorly 2 centimeter away from the upper GBS. Externally involving the skin, about 1 into 1 centimeter size, the skin of cheek along with the right commissure, and the single 1 into 1 centimeter oval hard mobile lymph node was present at the right level 1. After clinical examination and the clinical examination, my diagnosis was the right buccal mucosa carcinoma, and the clinical staging was CT4A-N1 MGP, and it was involving the skin, so it was T4A, and there was a hard node over the level 1E, so it was involved. Then I have to confirm my diagnosis and the stage my disease and as well as management of the patient. To confirm the diagnosis, we have done the punch biopsy, which came out as a well-differentiated squamous cell carcinoma for this case. Then to stage the disease, we have done the blood investigation and as well as the radiological investigation. Here we have done the whole body PHCP, which is a single modality of choice to see the local extent of the disease as well as the distant metastasis for this case. Whole body PHCP, which came out as a 1.7 into 2.9 into 2.4 centimeter in size, right buccal mucosa, and the lower GBS without any bony, no obvious bony erosion in the body of the right any mandible. The lesion was infiltrating overlying skin of buccal mucosa, maxillary muscle and the subcutaneous plane reaching up to the skin. And we can see the lesion is here involving the right buccal mucosa as well as GBS, but there was no bony erosion present over the, no particular erosion of the bone present over the here and as well as the, but it is going up to the skin. The final diagnosis is a 45-year present lady who was a tobacco chewer, and the diagnosis is the well-differentiated squamous carcinoma of the right buccal mucosa. The name staging is the CT4A-N1 MGP. Then multidisciplinary team discussion was done, and after that the surgery was planned, which was the composite resection, nail resection as well as the microvascular reconstruction. The pre-operative workup was done, and the fitness from the anesthesia department was taken, and the counseling regarding the surgery and post-operative management about the patient was done, and as well as informed written consent was taken. The surgical procedure, we have the wide local excision of the right buccal mucosa and the lower GBS lesion with the skin lesion, taking 1 centimeter clear margin all around, along with the marginal mandibulectomy. And we can see we have to dissect the upper part of the mandible, and the marginal mandibulectomy means we have to keep minimum 1 centimeter height of the mandible, so that just maintain the stability of the membrane. And we have done here the right modified radical neck dissection type 3. That means we have to preserve the sternocleidomastoid, the IJB, and then as well as the spinal accessory nerve. And the reconstruction was done by the plastic surgery team, left forearm 3 flap reconstruction, and with the skin thickness skin nerve. Post-operatively, after surgery, the patient was intubated and shifted to the SICU and placed on ventilator. Post of day 1, patient was extubated and the right street feeding started. And post of day 2, patient shifted to the ward. On post of day 3, we have referred the patient for the physiotherapy department for the management of the mouth opening exercise as well as pain and the limb exercise, as there was failure for the treatment was done. So the limb exercise and
such wonderful insight on the surgical and clinical aspect. I'll be covering the physiotherapeutic aspect of the case. So, a female of 45 years who was a housewife was referred to the physiotherapy on post-operative day 3 by the Surgical Oncology department. She presented with a chief complaint such that patient complained of pain on the right buccal and neck region and difficulty in right shoulder movements, as well as difficulty in mouth opening post-surgery. When we inquired about the history of present illness was as such. It was a non-healing ulcer of right buccal mucosa. Since last 2 to 3 months, there was no known comorbidity or no known allergy. Personal history was as follows. The patient had a habit of chewing tobacco since last 20 years, but there was no family history of malignancy. The surgical history. Patient has undergone wide local excision of right buccal mucosa and lower GBS lesion with skin lesion and marginal mandibulectomy. Right modified radical neck dissection type 3 and left forearm free flap reconstruction, as well as split thickness skin grafting on 21st September 24. When we did the pain assessment, we came to know that the site was right buccal as well as the neck region. It was a dull aching pain which was consistent post-surgery. The aggravating factors were the facial movements of the patient as well as when the patient tended to sleep on the affected side, that is the surgical side, which was right. The relieving factors were rest as well as the medication. When we marked the pain on the pain score, that is the NPRS, we used that. It was rated as 7 by the patient. On observation, we saw that the body build of the patient was ectomorphic. That means the patient was lean body type. We had seen that there were surgical stitches over the right buccal and neck region, bandaging on the left forearm due to radial free flap, bandaging on left thigh due to skin graft taken from the mid-thigh region, as well as there was an embryo on the right side and a nasogastric tube for feeding. The type of gait was intelligent because patient was tending to not put pressure on the affected side. So their stance phase was minimized on the left side. There were no deformities as such. The posture of the patient when seen, patient had rounded shoulders as well as a forward head posture. We assessed the mouth opening of the patient on POD3, which was 30 mm. We used the instrument, namely vernier caliper, to do the same. Sensorium. Patient was conscious and alert and the sensorium was intact. Patient was somewhat anxious but was coping well. When we saw the ambulatory status of the patient was able to walk a few meters, that is 10 to 20 steps, but with assistance from the attendants. Balance and coordination was checked on the Buccal balance scale and the score was 46. That means there was a functional balance present. Thus, we can put the patient on the mobilization program. Other symptoms like dizziness, nausea or breathlessness was not present. On palpation, when we palpated the right buccal and neck region, we saw there was a grade 2 tenderness present, which is patient complains of pain and winces a bit. Temperature, there was a slight localized temperature raise, whereas the general temperature was 19.2, patient was atrial. Swelling, there was a post-surgical swelling present over the buccal as well as the neck region. There was no abnormal sounds present. On examination, we saw the vitals. Heart rate was 90 beats per minute. Respiratory rate was 16 breaths per minute. Blood pressure was reported as 140 by 90 mmHg and SpO2 was 97%. Further, we investigated the manual muscle testing for the strength of the muscles. We saw that in the right side, that is the surgical side, the shoulder muscles show weakness in flexors, abductors, external rotators as well as the internal rotators. Rest all the muscles were in the normal range of MMT. Further, in the elbow region, since free flap was taken from the left side, there was a slight change in the strength of flexors, extensors, supinators as well as the pronators. Wrist region was not much affected. When we took the MMT for the cervical region, we saw it was for the flexors was -3. We couldn't test the extensors because of the restriction due to stitches, and lateral flexion was again -3 in the MMT grade. When we assessed the hip, flexors and adductors were affected just because of the skin graft being taken from the left side, and the knee flexors and extensors were also affected. Rest all the readings were in the normal range. When we assess the range of motion of the patient, the deviation was seen in flexion 150 degree, extension 50 degree, abduction 130, external rotation and internal rotation as 70 degree each. In elbow joint, we saw that the flexion was 110 degree, supination and pronation were 70 degree each. Other ranges were in the normal range. Cervical range was affected such that flexion of the cervical was 40 degree, extension 15 degree, lateral flexion on the right side was 30 degree, and more is affected on the left side due to stitches. It was 10 degree. Hip joint flexion was 100 degree, adduction that was affected was 20, external rotation affected 40 degree. And the knee joint flexion was also affected, which was 110 degree. Rest all of the ranges fell in the normal range parameter. Further, we did the functional assessment of the patient, in which we used 2 scales. First was the functional assessment of cancer therapy, head and neck, in which there are various components like physical, emotional, social. There is a questionnaire in which we do subjective assessment based on the patient interpretation of their condition, and then we mark the scale. On POD3, the assessment was 52 on 148. Similarly, we did another assessment for neck disability index. It is a 10 questionnaire scale in which there are 5 outcome measurements that we mark, and the patient reported it as on POD3 32 on 45. After this, we have to plan the treatment protocol. We have to set our short-term and long-term goals as well as educate the patient. How it was done will be covered by our resident, Dr. Manisha. Thank you so much.
We have understand the entire aspect, the medical, surgical and the physiotherapeutic aspect, because together we can make the best treatment for our patients.
Good afternoon, I am Eshita Sharma, PhD resident first year, going to present the physiotherapy management of the case of Indian with cancer of right buccal. So starting with the goals, we have divided our goals into short term and long term. First, short term goals. First one is patient education, then to maintain the functional capacity of the lungs, to improve and maintain the range of motion and strength, management of pain, reduce the swelling, to improve the tongue movements, to improve the oral activities and swallowing, then maintain the mobility. Coming on to the long-term goals, prevent further complications like trichomonas, that is long, and others such as respiratory and circulatory complications. Then early initiation of progressive functional activities, then improve self-esteem, improve overall conditioning of the patient. Now, patient education. In this way, we will make the patient aware of the ongoing condition and the requirement of physiotherapy for its management, and also tell about the some do's and don'ts that you should follow for the better outcomes. First, do's: follow wound care instructions, then maintain good oral hygiene, do all the exercises regularly, rest adequately, regular follow-up visits, maintain good posture. In don'ts, avoid smoking and alcohol consumption, as it can interfere with the healing process and can increase the risk of infections. Then avoid overexertion of neck muscles, don't force the jaw movements, Don't skip exercises. Avoid poor posture. So we started our intervention from POD3. In chest physiotherapy, first one is deep breathing exercises. For all the deep chest physiotherapy exercises, the patient should be in relaxed and comfortable position with the shoulder and neck muscles relaxed. First is deep breathing exercises. For this, take slow and deep breath through the nose, then exhale through the mouth. This will help the patient to relax. With 10 repetitions, then diaphragmatic breathing exercises. Place one hand on the chest and one hand on abdomen. Now slowly breathe through the nose and allow the abdomen to expand and upper chest wide. Then exhale through the mouth. This will help the patient to prevent the use of accessory muscles. Then pulse lip breathing exercise. Inhale slowly through the nose, then pulse the lip as you are going to whistle. Then exhale slowly and gently through the pursed lips. This will improve the ventilation as well as decrease the stress of the patient. In limb physiotherapy, hamstring and quadricep isometric. For static quadricep isometric, patient should be in supine position. Then place a roll towel under the knee. Then command the patient to apply pressure by pressing the knee down and hold it for 10 seconds while pull the toes up toward the shin bone. Then repeat 10 times. For hamstring isometric, place the roll towel under the heel and press it down. Hold it for 10 seconds, then repeat 10 times. Second is active range of motion exercises of bilateral, upper and lower limb with 10 repetitions, then shoulder shrugs. For this, bring the shoulders as high up towards the ears as you can while inhaling through the nose. Then lower the shoulders back down while exhaling. With 10 repetitions in neck exercises, active range of motion exercises within pain-free range. Then neck isometrics. So these are the exercises that involve a contraction of muscle without any movement. For this, we will apply the resistance manually and tell the patient to resist it by contracting the neck muscles. This will help the patient to strengthen the neck muscle as well as improve the stability of the neck. Initially, we are going with the 5 repetition with 5-second hold. In mouth exercise, tongue exercise, it will include the tongue protrusion, retraction, elevation, tongue side to side. In mobility, bedside sitting with ankle toe movement for 10 minutes. So this is the video of quadriceps isometric. Now this is the video of shoulder shrugging. Intervention on POD4. In chest physiotherapy, we add one more exercise, that is thoracic expansion exercise. For this, take both the hands away from the body while slowly inhaling through the nose. Then take the back to the initial position while exhaling. In limb physiotherapy, we are going with the same exercises and neck exercises also. In mouth exercise, along with the tongue exercises, mouth opening and closing exercise, mild shaker's maneuver. For this, patient should be in supine position with the shoulders flat on the bed. Now, we will command the patient to lift the head to look at her toes and hold this position for a few seconds, then back down the head to the bed. This is the video of shaker's maneuver. This will help the patient to strengthen the suprahyoid muscle, which will enhance the swelling. In proprioceptive exercises, these are a series of jaw exercises which include 6 steps. But we are going with the step one only, that is tongue flaps. For this, place the tip of the tongue against the roof of the mouth, just behind the front teeth. Now diaphragmatically breathe when the tongue is in resting position. In mobility, bedside sitting with dynamic quads. Then POD4, patient was able to walk with assistance 30 steps. This is the video of dynamic quads with minimal resistance. Now intervention on POD5. In chest physiotherapy, we are doing the same exercise but we are holding the breath for 3 seconds. Limb physiotherapy, we replace the shoulder shrugs with the therapeutic exercises for the strengthening of the shoulder muscle. In neck exercise, we progress the neck isometrics from 5 repetitions with 5-second hold to 10 repetitions with 10-second hold. Mouth exercise, continue the same exercises. In mobility, we progress the walking with assistance to 30 to 50 steps. This is the video of patient walking with assistance. Now intervention on POD6 in chest physiotherapy, limb physiotherapy, neck exercises and mouth exercises. Continue the same exercise in mobility, walking with assistance 80 steps, and on this intervention, the patient was able to walk without assistance 20 steps. And this is the video of patient without walking without assistance. Now intervention on POD7. In chest physiotherapy, limb physiotherapy, neck exercises and mouth exercises. Continue the same exercise in mobility, walking with assistance 100 steps, walking without assistance 40 steps. So on POD7, we assess the patient for the progression, and these are the ranges, the highlighted ones that we achieve on the POD7. So for shoulder flexion, right side 150 to 165, for shoulder abduction 130 to 145, for ankle flexion left side 110 to 115, cervical flexion 40 to 45. In lower limb, hip flexion left side 100 to 110, hip adduction 20 to 30, hip external rotation 40 to 45. Knee flexion left side 110 to 150. And this is a pain score which was 4 out of 10 on POD7. Mouth opening was 57. Functional assessment of cancer therapy head and neck scale 97 out of 148. Neck disability leg score 15 out of 45 on POD7. Now last is home exercise program. Continue all the above exercises, then progression of exercises to be done according to the patient follow-up. Facial expression exercises that include smiling, frowning, puffing cheeks, lip pursing to strengthen the muscles, and biofeedback using mirror for the facial exercises, then progressive ambulation under supervision.